So somehow the sound fell off of the previous version of this, so let's do it again. So dermatology and the pharmacology that addresses it. So one of the big things in primary care that we'll see for derm is acne. And the biggest issue for acne is trying to decide whether it's inflammatory or non-inflammatory. If you have someone who has a non-inflammatory acne or a mild inflammatory acne, then you can definitely do a topical treatment approach. And the proactive actually has 4 elements to it usually. And they're a cleanser, which I like, just one of the oil-free cleaners. Neutrogena has a good one. An exfoliant like salicylic acid, the pads are a good one for that. And then an antiseptic like 2.5% benzoyl peroxide. I never go stronger than 2.5 because it'll cause a lot of irritation and they'll actually get worse before they get better. And then if this has caused drying, then you use a moisturizer. Topical retinoids are now available over the counter. Differin is the example that is the best demonstration of that. They basically bind up a couple of these receptors and stop the pimples from occurring. And so they're pretty effective, they're pretty safe, and as noted, they are available over the counter now. That is ADAPALENE, which is different. It's a 3rd generation retinoid. And it does seem to definitely make a substantial improvement. You can also use topical antibiotics. Unfortunately, a lot of the bugs that are associated with acne are becoming progressively more resistant. And so the topical erythromycin and clindamycin may be worth a try, but unfortunately, they're not usually that effective. Generally, you'll want to combine them with retinoids and benzoyl peroxide. And in general, they also decrease the resistance if you do that. DAPSONE is still a prescription. It's an immune modulator. It's very expensive. Last time I checked, it was between $200 and $400 a tube. It has some oral anti-inflammatory, some anti-inflammatory effect. And the oral DAPSONE is even more effective at that. Like many antibiotics, we're now finding that they have anti-inflammatory effects. And so that is another option. Many people will leave this one for the dermatologist and just go with the basics. And then if the acne is cystic, then they'll use an oral antibiotic such as tetracycline. And then if that doesn't work, then they'll refer to dermatology. And again, here's a little bit more information seeming to demonstrate that the DAPSONE is pretty effective. So if it's inflammatory acne, then you're probably going to need an oral antibiotic at least to knock it down. Cystic acne is the other way of thinking about this. Minocycline is a great medicine. It's a little more expensive than tetracycline or doxycycline. Most primary care people use the doxycycline, but most dermatologists will use the minocycline. You can use oral antibiotics in other forms. Erythromycin, unfortunately, that often causes a lot of nausea. Cipro, we're now worried about that causing tendon issues, so it is black box for that. Bactrim is a great drug for acne. You just have to warn them that if they get a rash that they're probably going to have to come off. And you can just use the trimethoprim component of Bactrim. Unfortunately for that, even though it's fairly cheap in Bactrim, the isolated version of trimethoprim is a bit more expensive. Other medications that you can use for acne, oral contraceptives are very effective. Many women, when they reach that age of having periods, will often break out. And putting them on an oral contraceptive, especially one with a relatively low androgenic element to it, will often end up decreasing the amount of pimples. Spironolactone is also a pretty good androgen blocker, so that tends to work pretty well, especially if you happen to have someone that has PCOS type symptoms, because they often have that constellation of a little bit of the obesity, a little bit of hirsutism, and hyperandrogenism, including hirsutism and often acne. Accutane is a medicine that I believe should relatively be reserved for the dermatologists. It can't be used in pregnancy. You have to be very careful monitoring certain laboratory tests, but as noted, it's very effective. I've had probably half a dozen kids that went to dermatology, and within a couple of months, since we had tried all the basic stuff, they were on the Accutane and they got dramatic response. Red flag rashes. I'll see if I can put this link on the YouTube. Just a very few red flag rashes, and you just want to know what they are. You know, if you got somebody with scalded skin syndrome or Stevens-Johnson syndrome or something like that, you need to recognize it. But this slideshow actually does a really good job of reviewing that. A lot of primary care people practice dermatology by the old saying of if it's wet, dry it. If it's dry, wet it. When in doubt, you use steroids. Unless it moves, then you kill it. It's a very simplistic way. Sometimes it does help. And then if it doesn't work, usually people will refer to dermatology. But as I say, if you can be a little bit more sophisticated than that, that might be a good thing. Topical steroids, they come in low, medium, high, and super high strengths. And so, you know, you need to be aware of what those are. There's good charts out there that'll tell you which is which. In general, you can use over-the-counter hydrocortisone for a lot of things. And then my medium topical steroid that I use is triamcinolone, which is especially appealing because it comes in a 454-gram tub. So if you have somebody that has a lot of area, you can use it. Topical antifungals, and we talked about the antifungals in the infection section. But basically, if you've got somebody with tinea, cruris is in the crotch, pedis is on the feet, and then capitis usually requires oral antifungals, and then bleach. Some wrestlers will treat their tinea cruris and their tinea corporis with bleach. Probably not the best idea, but most of the topical antifungals will actually work really well. Again, sometimes you'll need to use a little bit of diflucan or something like that. But and again, just to review the four major families of the antifungals: the polyene family, which is nystatin; the azoles, which the over-the-counter version is Lotrimin. Lotrazone is actually that with a steroid in it, so obviously that's something you're going to use much more cautiously. The allylamines are the Lamisil. It's less effective against Candida, but it is more effective against most of the other the funguses that you'd want to use it on. And then tolnafdate is tough-actin tinactin and fast-actin tinactin, and they work pretty well for most of the other fungi. Herpes zoster is a rash which occurs usually on the side, on the flank, but sometimes can be on the face and various other places. Acyclovir works well for it, but it has to be given 4 or 5 times a day. So most people use valcyclovir, which is 3 times a day. And here's the doses for the 3 most common ones given. And people under 50, we don't usually give steroids because there's not really any evidence that they help. But people over 50, we tend to give them to decrease the amount of pain. It probably does not decrease the incidence of postherpetic neuralgia, but people over 50 will often get pretty good relief with their pain with steroids. Prednisone added to zoster does seem to decrease the pain, as noted. Lots of different options. You can try nortriptyline or amitriptyline. I find those are a very modest benefit. Oftentimes these people will need narcotics for a week or 2, and then can probably manage with just the nerve blockers. But unfortunately, I don't find that if you have somebody that has a very painful zoster that you know, gabapentin or any of these other medicines are that effective. Herpes zoster 1, or oral herpes, usually we use valacyclovir 2 grams PO once and then 12 hours later, and then you're done. Famvir usually is 7 days, and acyclovir is actually 5 days. Acyclovir is not FDA approved, but just because they didn't go in for an indication, it does seem to work just as well as the others. Most people, again, use the Valtrex because it's just a single-day treatment. And the herpes zoster 2, you can get it anywhere where underneath where you'd have boxer shorts, and it does seem to be pretty effective to use the antivirals. It will never be cured, however. They will always have it, but they can suppress it and keep it under control. And again, here's the dosing, which is similar, but for recurrent episodes, it's not going to be as long. The other was for initial. And for chronic suppression, you can actually just put somebody on a gram of Valtrex once a day, or on acyclovir twice a day. Acyclovir tends to be a lot cheaper. It's on the Walmart $4 list. Erythrasma, if you have somebody that has tinea cruris and they're just not getting better with antifungal treatments, you have to consider the possibility that it isn't a fungus, that it's in fact a bacterial infection. The best way to tell is by using the Woods lamp, and it will fluoresce. I'll show you that picture in a minute. And what you can do is you can use a little bit of clindamycin or erythromycin topical creams or lotions to knock that down, and it'll usually go away and doesn't usually recur. Erythrasma is what we're talking about, and when it coalesces, it does this like cobalt blue color when it fluoresces. And again, you can use oral treatment or you can use topical treatment. And psoriasis usually happens on the extensor surfaces. If you got something that's on the flexor surfaces, it's more likely to be eczema. If it's on the extensor surfaces, it's more likely to be psoriasis. Many people can be managed with just emollients and a little bit of occasional topical steroid. Unfortunately, oral steroids usually makes them worse, although sometimes people are so bad you have to do that before you can get them into dermatology. And there are also a number of disease-modifying anti-rheumatic drugs that are also used for psoriasis, methotrexate, the retinoids, cyclosporin, and the TNF-alpha inhibitors, including a number of monoclonal antibody medicines. So there's been pretty major advances, and I think that we've made some progress here, but a lot to learn in dermatology, rarely life-threatening, but very often quality of life threatening. So good luck.